Hello, everyone. Welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host, Sattam Almezied,
Shout out Kleja.
and today we're joined by,
Abdurrhman Khan.
shout out Guyana, to dive into panniculitis and vasculitis.
Hi everyone, it's great to be here today. Today's topic looks scary on paper, and I ain't gonna lie to y'all, it is scary on exams too. If you ever seen a derm slide full of lymphocytes, neutrophils, eosinophils, and weird words like fibrinoid necrosis and thought, yeah, no thanks, then this is the episode for you. We're going to go slow, step by step, and turn these monsters into something that makes sense, and maybe even is something fun.
Okay, let's dive through the skin and right into the subcutaneous fat to talk about panniculitis.
Okay, so the name includes itis. Do you want to take a guess at what that is?
Well, everyone and their mother knows the suffix itis means inflammation.
Facts. Panniculitis means inflammation of subcutaneous adipose tissue. Clinically, it shows up as tender nodules or plaques in the subcutis, often on the legs. Now, histologically, fat is generally arranged into lobules separated by fibrous septa, kind of like segments of an orange separated by the white fibrous thingy you always have to peel out. So obviously, it can be different depending on where the problem is.
So what you're saying is that panniculitis can be of different types?
Correct. You can have septal panniculitis, lobular panniculitis, or mixed. Any idea on how we figured this out?
I'm assuming a shallow shave biopsy isn't enough, right?
Exactly. You need a deep biopsy. It needs to reach all the way to the subcutis. Otherwise, you'll miss the main action. It's all below the skin. We have two classic types of panniculitis, erythema nodosum and erythema induratum. We'll hit y'all with a quick case scenario so we can start breaking them down.
A lot of doctors dismiss her symptoms as anxiety, but considering you're a 6'2" feminist, what's the first thing that comes to your mind?
Actually, it's 6'3". That's classic erythema nodosum, the most common form of panniculitis. Clinically, erythema nodosum shows up as poorly defined, tender, erythematous plaques or nodules on the anterior shins. They're often more easily felt than seen, and importantly, they don't ulcerate, and they don't leave scars. Over time, they flatten out and fade away with classic bruise-like color changes. Patients may also have fever and feel unwell.
Okay, I get it now, but what does this look like histologically?
Histologically, erythema nodosum is a septal panniculitis without vasculitis.
Septal panniculitis. So the inflammation has to be in the fibrous septa.
Yes, sir. Early lesions show widened septa between the fat lobules. That's because of edema, fibrin exudation, and neutrophil infiltration. As the lesion evolves, you start to see chronic inflammation with lymphocytes, histiocytes, multinucleated giant cells, and even occasional eosinophils, along with septal fibrosis. Again, no vasculitis.
Okay, we understand how it works now. But what causes it?
So it's usually caused by post-streptococcal infections, pregnancy, use of oral contraceptive pills, sarcoidosis, Behçet disease, shout out Turkey, hematological disorders, and chronic infections.
I remember and all that. Hopefully the treatment is simple though.
Yeah, while it can look dramatic at times, most cases respond to simple measures like rest and NSAIDs. If it's more severe, we use oral steroids, and in some situations, medications such as potassium iodide, dapsone, or colchicine.
Now, what about the erythema whatchamacallit, the other one?
Erythema induratum. It usually happens in people our age and menopausal women. Historically, it was considered a hypersensitivity reaction to tuberculosis, but now it's often seen without a clear underlying disease. Clinically, it presents as erythematous, aka red, slightly tender nodules on the legs, especially the calves/the posterior leg. And unlike erythema nodosum, the nodules in induratum can ulcerate.
And would you be so kind as to enlighten me on the histology in this case?
Yeah, so erythema induratum is a lobular panniculitis with vasculitis. You see granulomatous inflammation inside the fat lobules themselves, with areas of caseous necrosis in the fat, very TB-like. And in early lesions, you see necrotizing vasculitis, a small to medium-sized arteries and veins, in the deep dermis and subcutis. This is all unlike nodosum, which was in the septa and had no vasculitis.
Makes sense. But just to emphasize the difference between nodosum and induratum, erythema nodosum has septal inflammation, no vasculitis, and no ulceration, while erythema induratum has lobular granulomatous inflammation with caseous necrosis, necrotizing vasculitis, and possible ulceration. Okay, now let's zoom out of the fat and into the blood vessels. Let's talk about vasculitis.
Vasculitis means inflammation of the blood vessel wall. This can be limited to the skin or part of a systemic disease. Let me just mention the histology while I'm at it. Vasculitis is characterized by fibrinoid necrosis of the vessel wall, a neutrophilic infiltrate in and around the wall, aka inflammation, extravasated red blood cells because the vessel wall is damaged and leaky. And finally, since it's an autoimmune process, most of the time immunofluorescence is positive due to there being deposited immune complexes or complement.
Okay, I understand the textbook stuff now, but what would that look like on a patient?
Yeah, forget all that nerdy stuff. When you take a look at the patient, they'll have non-blanchable, palpable purpura. Non-blanchable means that the rash won't disappear when you press on it. And that's because the RBCs have already leaked out of the vessel and into the tissue.
Okay, seeing as I'm a second year who hasn't taken this lecture yet and it just sounds like you're speaking gibberish, how would you simplify vasculitis to me?
So basically, I'd break it down into 4 core questions. First things first, you'd ask, is it vasculitis? And that's where you look for palpable purpura, ulcers, livedo pattern, and nodules. Then you confirm with a biopsy showing the classical histological features we mentioned.
Which were positive immunofluorescence, fibrinoid necrosis, neutrophilic infiltrate, and extravasated RBCs around the blood vessels, right?
Exactly. After that, you ask, is it isolated to the skin or are other things involved? So you must check other organs, especially the kidneys, which are the most important prognostically. And you also check the joints, GI tract, lungs, and the central nervous system.
And the third question is?
What is the cause? We need to determine if the vasculitis is just idiopathic or if it's secondary to some underlying cause like infection, autoimmune connective tissue disease, drug, or neoplasm.
All right, makes sense. Now, what's the final question?
You need to ask yourself, how can we manage it? And if you should even treat it at all. If it's skin limited and mild, you can probably get away with only treating the symptoms. If it's skin limited but severe, you need to start considering using systemic steroids. And if it's steroid dependent, you can add drugs like dapsone, colchicine, or other immunosuppressants. If it's a systemic condition, you usually go straight to systemic corticosteroids plus immunosuppressive agents.
Now that you've yapped a little bit about vasculitis, we should probably go over the classification of its different types.
Yalla, let's go. We classify vasculitis based on the size of the vessels involved. So whether they're small, medium, mixed small and medium, or large vessels.
How about we go from smallest to largest first?
Okay, sounds good. So starting with the small vessel vasculitis, this includes IgA vasculitis, also called Hinoch-Schönlein purpura, shout out BMW, and urticarial vasculitis. IgA vasculitis is an important one to remember. Usually you see it in children that had a recent respiratory infection, but it may also be seen in adults. It appears over the legs and bum, and you would see IgA immune deposits in blood vessels on immunofluorescence.
Okay, IgA vasculitis in a child after a respiratory infection. How about the next group?
The next group would be the mixed small and medium vessels, which are affected in cryoglobulonemic vasculitis, and the 3 ANCA-associated vasculotides, which are microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis. Microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis are both P-ANCA associated. The eosinophilic one is called Churg-Strauss syndrome, and its patients usually present with asthma, hence the eosinophils. Granulomatosis with polyangiitis, or GPA, which was previously known as Wegener's granulomatosis, is the only one associated with C-ANCA, and it usually affects the lungs and kidneys.
So what you're saying is small vessel vasculitides are IgA vasculitis and urticarial vasculitis, while the mixed small and medium ones include the ANCA-associated vasculitides and cryoglobulinemia. Specifically, P. ANCA is seen in microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis, while C. ANCA is seen only in granulomatosis with polyangiitis. Okay, that brings us to the next group, which is the purely medium vessel vasculitis, not mixed.
Yes, that group includes Kawasaki disease, shout out motorcycles, and polyarteritis nodosa. Kawasaki disease is famous for coronary artery involvement, so it affects the heart. While polyarteritis nodosa, PAN, affects medium-sized arteries in multiple organs, including those of the kidneys and testicles, among others.
Okay, cool. Kawasaki, shout out Madagascar penguins, affects the coronaries, and polyarteritis nodosa affects the kidneys, and both affect medium-sized vessels. What about the large vessels?
Those are temporal arteritis and Takayasu's arteritis. Temporal arteritis affects the temporal artery on the side of the head at your temple. On the other hand, Takayasu's arteritis affects the aortic arch, and patients present with a very faint pulse because blood is not getting distributed efficiently.
So, large vessel vasculitides are temporal arteritis and Takayasu's arteritis. Now that we've explained everything, let's give our listeners a quick practice question. And since our explanations were literally perfect, y'all shouldn't have a problem figuring this out.
Yeah, they were locked in for real. Don't worry, they won't get it wrong.
Inshallah, let's see.
A patient comes in with palpable, non-blanchable purpura on the legs. A skin biopsy shows fibrinoid necrosis, neutrophilic infiltration, and RBC extravasation in small vessels. What is the general diagnosis for these histological features?
Those features are what we see in vasculitis, fibrinoid necrosis, neutrophilic infiltration, and RBC's extravasation. This is in addition to the positive immunofluorescence.
Round of applause to all of y'all that got it right.
Loki, if you didn't answer that, you're a bum. But I know a lot of people's attention spans are cooked by Reels and TikTok, though, and I'm people, by the way. So here's a quick recap.
Oh boy, here we go. First, we dropped into the fat with panniculitis, where we said that erythema nodosum is a septal panniculitis without vasculitis, giving tender, red nodules on the shins that don't ulcerate and heal like bruises. Causes include post-strep, pregnancy, OCPs, sarcoidosis, Behçet, hematological disorders, and chronic infections. Histology shows edematous septa initially with neutrophils and later lymphocytes, histiocytes, giant cells, and septal fibrosis. The second type of panniculitis is erythema induratum, which is a lobular granulomatous panniculitis with necrotizing vasculitis of deep vessels, often in adolescents and menopausal women, with nodules that can ulcerate, and caseous necrosis in the fat lobules.
All right, and to recap vasculitis, it's defined histologically by fibrinoid necrosis of vessel walls, neutrophils, and extravasated RBCs, along with positive immunofluorescence in most cases. Clinically, it often shows palpable purpura, which is a rash. It can be limited or systemic, hitting organs like the kidneys, joints, GI, lungs, or the central nervous system. We classify them based on the size of the vessels affected. Treatment ranges from only treating symptoms to systemic steroids and immunosuppressants, depending on the severity and systemic involvement. When it comes to the different types of vasculitis, think of IgA vasculitis in a child after a respiratory infection, and remember there are IgA deposits, hence the name. Then we have the ANCA-associated ones, P. ANCA seen in microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis. Keep in mind the relationship between asthma and eosinophils in this case. While C. ANCA is seen only in granulomatosis with polyangiitis, which affects the lungs and kidneys. Then you should also know that Kawasaki affects the coronaries and polyarteritis nodosa affects the kidneys. And finally, temporal arteritis affects the temporal artery at your temple, while Takayasu's arteritis affects the aortic arch and causes a very faint pulse.
So the main question you have to ask yourself would be, where is the problem in the skin? What's being attacked? Is it fat septa, lobules, or vessels? And how does that show up clinically and histologically?
Thank you for actually explaining it in a cohesive way. And that wraps up today's episode on panniculitis and vasculitis. Abdurrhman, thank you for guiding us through this minefield of inflammation and fibrinoid necrosis.
Always a pleasure. And to everyone listening, if you ever feel overwhelmed looking at a derm question, just slow down and ask yourself, where is it? What's being attacked? And suddenly it's not so scary.
If you found this helpful, don't forget to follow PodBites and share this episode with a friend who's currently beefing with dermatopathology. Or if you find yourself at that dangerous moment when you think, let me scroll for just 5 more minutes, stop and listen to PodBites instead. We'll be back with more bite-sized episodes soon.
Until then, take care, and we'll catch you next time on PodBites. God bless. Bye everyone.